Thank you very much, and greetings to everybody. I want to thank Khaled once again for the opportunity to be here with you. It just isn't the same without a year to spend with you, and I just love how much thirst there is for information and enthusiasm to do right by the children. Normally, I've talked a lot about diabetes at this forum before, about theoretical things, preventing type 1 diabetes, and there's a lot going on there, but I thought this year it would be important to focus on very practical things, and developments that are available now that are really revolutionizing how we manage and how we evaluate type 1 diabetes in children. And I'll end with a couple of comments about potentially new developments. So we're going to talk about ways in particular today to assess blood glucose, capillary blood glucose, that's finger sticks, versus continuous glucose monitors, which are becoming quite commonly used in our pediatric population, and in particular software tools to help us make the most of the data that we collect. It's not hard to get data from kids. Well, sometimes it is hard to get data from kids. The old-fashioned way was to write them down in a logbook, and oftentimes the logbook was totally fiction. They wrote down numbers. Even after we could download meters, a lot of times you'd be going through numbers with them, and they'd say, well, I think that one was right when I had right after breakfast. Well, it's not helpful when you don't have consistent data. So I want to talk about some interesting software tools. I want to talk to you about the kind of pros and cons of using insulin pumps, which we call CSII, continuous subcutaneous insulin infusions. That's kind of the shorthand term, versus multiple injections of insulin. And I'll update you. We talked last year about the about to be released, but now we've had a year of experience with closed loop insulin pumps. And finally, to talk about new insulin analogs and the possibility of intraperitoneal insulin. So, key thing is, why does diabetes control make a difference? Why do we spend so much effort to try and keep the glucose normal? When I was in medical school, this was in the middle 70s, when I was in training in the late 70s, early 80s, it was a raging debate as to whether it made any difference in the development of diabetes complications as to what the blood sugar had been. There were two strong camps that thought blood sugar control had no impact on later development of complications, and they were firmly entrenched with data too. And another group that said, yes, diabetes complications are clearly linked to the glycemic control. The problem was we had no good way to assess these things. And in the early 80s, two major developments came along that made this a testable hypothesis. One is home glucose monitoring, which was not done in the 70s. In the 1970s, people used to test their urine for glucose maybe twice a day. The other thing was the Hemoglobin A1c measurement. I won't go into detail. I'm assuming most people are quite familiar with that. It measures the glycosylation state of hemoglobin A in the blood, but it's a reflection of the average blood glucose for the past 3 months. So with a hemoglobin A1c measure, you could actually get some quantifiable data as to how good was the control in the period before that. So why does it make a difference? Well, because glucose control definitely makes a difference. Improving glucose control dramatically reduces diabetes complications, microvascular and macrovascular complications. And what came out of this trial, called the DCCT, the Diabetes Complications and Control Trial, was the fact that the older ways of taking care of diabetes were clearly not good enough, and something had to change. Good things have happened as a result of the changes, but it's been much more cumbersome for the patients. So this, just to conclude on this, the DCCT, that's the data there. But let me just focus down here for a moment. 1,400 patients with type 1 diabetes were followed for up to 9 years. Average was like 6.5 years at 29 centers in a number of different countries. This ended in 1993. The conventional control group was the way things used to be done in the 70s, going back practically to 1922. They gave 2 injections of insulin a day. The insulins were the older, regular and ultra-lenti, or regular and NPH. The conventionally controlled group did not meet with their doctor with any regularity. They came back to clinic every 3 months. They tested their glucose either in the urine or with a home glucose meter twice a day, and they gave no more than 2 injections of insulin. The intensively controlled group had the same insulins. This was before we had Aspart and Lispro, the analog insulins that we'll talk more about in a minute. And the intensively controlled group, they gave at least 4, they checked their blood glucose, not urine, at least 4 times a day, and they gave an injection of insulin at least 3 times a day with each meal and coverage for overnight with a ultra-lenti insulin. By today's standards, those were very primitive insulins, but look at the difference. At the end of the period of study, the intensive group had an average blood glucose of 155. That's a hemoglobin A1c of about 7.5. The conventional group had an A1c of about 10.5 or 230 milligrams per deciliter. And the difference in that degree of control from 230 to 150 showed these amazing reductions in retinopathy, nephropathy, neuropathy, cardiovascular events. And I'll say that since what used to be considered intensive control has become the standard of care, these sorts of decreases have been noted in the diabetes population overall. And so it's made a huge difference. Just one last comment about the DCCT. Here is hemoglobin A1c. There's the average blood glucose that these correspond with. But look how dramatically these curves are exponential. The relative risk for retinopathy, nephropathy, neuropathy goes up. There's almost a doubling of risk for every 1% that the hemoglobin A1c goes up. So it is imperative that we try and keep diabetes glucose control in a reasonable range to prevent long-term complications. So what are we expecting in children? The American Diabetes Association just recently redefined the criteria. It used to be that in younger children, we wanted the hemoglobin A1c to be below 8% and 7.5% for older children. Right now, the goal is less than 7.5% for all age groups. Now, if you can do better than that, it's encouraged, but without excessive hypoglycemia. We heard earlier that infants are particularly vulnerable to CNS damage through hypoglycemia. So we don't want to cause one problem trying to avoid another one. But the target is for preprandial glucose readings to be between 90 and 130 milligrams per deciliter, bedtime glucose a little bit higher, 90 to 140. If you're into millimolar, that I've got that there. These standards are published yearly, but this has been for the last couple of years. So that's what we're aiming for, a hemoglobin A1c in children, all children, whether they're toddlers or teenagers, of less than 7.5%. So this tells us how bad a job we're doing at this. Look at the age, this is age, this is the average hemoglobin A1c. This is 0, there's toddlers, 5-year-olds. We don't do too badly with infants and toddlers, but after age 5, and especially through puberty, you see that the mean hemoglobin A1c is close to 9%. That's terrible. These kids mature. There's a lot of reasons for this. It's the maturity of the child, it's psychological factors, it's physiologic too. During adolescence, there's a huge outpouring of growth hormone, sex steroids, other hormones that make the patient particularly insulin resistant. It's a more difficult diabetes to control than it often is in adulthood. But most of the resistance is between the kids' ears, and it's problems with accepting this very complicated regimen. So just to further clarify the ADA goals, glucose goals should be modified in children with frequent hypoglycemia or hypoglycemia unawareness. The longer you've had diabetes, you don't sense the autonomic shaking, sweating, the symptoms of impending hypoglycemia. So let's see what we're trying to do now. Let me just remind you, this is a profile of insulin levels in a patient without diabetes. So that's basically insulin secretion following 3 different meals. This is kind of Western, this isn't necessarily Jordanian meal patterns, but you see what happens to plasma insulin levels following meals. Clearly, there's no drop off to 0. There's a basal secretion of insulin overnight, and then these meals evoke an insulin release. Now, when we're trying to treat people, remember, we're giving injections of insulin subcutaneously. Now contrast that what happens in the normal setting. The sensor for your glucose level is not a meter, it's your beta cells. They're reading the glucose level in the portal vein blood. They secrete insulin into the portal vein. It goes directly to the liver. It targets the liver, which is its major source of action in terms of glycemic control. And there's a very, very short minute-to-minute regulation of glucose and insulin. Now, when we give injections, I'll show you the kind of conventional kind of treatment we give now with MDI, multiple daily injections of insulin. There's a long-acting insulin like insulin glargine or insulin detamers. Then these short-acting analogs, Aspart or Lispro, that are given at each mealtime. And when you do that, you're giving subcutaneous insulin, which gets into the peripheral circulation and eventually gets to the liver, but it ends up exposing the muscle and fat to 3 times the normal levels of insulin in order to get the right level at the liver. We're doing it backwards. If we had to devise an ideal way to treat diabetes, we would actually be infusing insulin into the portal vein. You see the problems with that. But in order to do what we're doing, we're exposing tissues that normally don't see as much insulin to very high levels, and we get fat storage, obesity, and we get frequent hypoglycemia. This is an insulin pump, the CSI measurement. It's essentially the same process at meals. You give what we call boluses, quick infusions of insulin, short-acting insulin to cover carbohydrates at meals. The one advantage that pumps have, though, is that the basal insulin can be varied. We set so many units per hour as a basal rate of insulin infusion, but we can change that at early in the morning hours. This is 4 a.m., this is 8 a.m. We can have it go up. In adolescents, we have this event called the dawn phenomenon, where they're secreting large amounts of growth hormone, in particular in the early morning hours. They need more insulin. Normal kids actually secrete more insulin during that time. We can make a pump do that, and we can have it go lower at other times in the day. I'll point out one other thing that distinguishes insulin treatment as we can do it now from what would be physiologic, and that is the width of this profile of insulin. Even with our shortest acting analogs, they're too slow and they last too long. It takes about 30 minutes for your blood glucose to eat after a meal. It takes 90 minutes for your short-acting insulin to peak. There's already a discrepancy there. And furthermore, the duration of the Aspart or Lispro is much longer than we need it. So we still have insulin working when we really don't want it, and we don't have it working off soon enough. So that was an initial insulin pump. They've gotten better. So let me just point out to you, there's 2 major distinctions in insulin pump that we typically make. So the Animas pump, which I think was available in Europe and probably here as well, is no longer on the market in the US. So that leaves us with the T-Slim and the Medtronic as examples of tube-delivered insulin. In other words, the pump and the brains, the computer that drives the motor reside in the pump, but the insulin is delivered through a tube. I'll show you the tubing in a minute, to an infusion site. So you've got tubing attached between yourself and the pump. The Omnipod, this is not showing up well, is actually right there. I'll show you a picture later. Is a pump in which the pump itself, the insulin reservoir, is on the patient. It's disposed of every 3 days, but there's a PDM, it's called, personal diabetes manager, that controls it. So the brains are here, this is disposable. So there's tubeless and tubed pumps. Inside of a pump is something like this, a reservoir that contains anywhere up to usually about 300 units, some pumps less than that, down to 180 units of insulin, a motor, a battery, and a computer chip that really drives this. There's some examples of reservoirs. This is a practical use because you can wear an insulin pump, an infusion set, for about 3 days. Every 3 days you have to change that out. But if you're a large adolescent that's using 150 units of insulin a day, you're not going to get 3 days usage out of any of the pumps that are on the market now, because 300, there's one tandem pump that has a slightly larger reservoir. But there are some limitations, and there are a lot of adolescents that will not put up with changing their pump every 2 days because it's more complicated than giving injections. And here's what the infusion sets look like. Essentially, they're I think, two features that distinguish them. One is whether the Teflon catheter goes straight into the patient or goes in at an angle. There's a version called the Silhouette that's for leaner individuals that don't have a lot of subcutaneous fat. It kind of tunnels at a 45-degree angle. That's one distinction, is the length and the angle at which the catheter goes in. The other one is the length of the tubing. If you want to wear it on your upper arm and you want to wear your pump on your belt, you need a longer tubing than if you were going to go from your belt to your abdomen. Okay, so I think I've said enough about what's entailed in the basal rate. There's essentially two things you can set there's actually three things you can set in a pump. The basal rate, and as I mentioned to you, that's units per hour that are delivered continuously. You can then subdivide that into various time periods. You can say between midnight and 2 a.m. it's going to be this long, 2 a.m. to 6 a.m. it's this high. You can change that. But it has a very precise delivery, and this makes it, in my mind, ideal for infants. You'd think, like, why would you have infants on a pump? There's issues about infants pulling out the pump, but they can deliver very precise doses of insulin. So that's the basal rate, covering that part of that curve. And then we have the bolus, which is basically based on a carbohydrate ratio. In other words, we want to say 1 unit of insulin in this particular patient will result in complete coverage of so many grams of carbohydrate. It could be in a toddler as high as 1 unit for every 45 grams of carbohydrate, or it could be greater. It could be 1 unit for every 5 grams in a heavy-set adolescent. So that's a variable you put into the pump. And you can change that at different times of day. Breakfast could be a ratio of 1 unit for 8 grams of carbohydrate. It could be 1 to 10 at lunch. You can make that variable throughout the day. And I won't go into active insulin time at the moment. The advantages of insulin pumps, it eliminates individual injections, and that's great for some people. It's more accurate. It's far more accurate. You can give, with an insulin pen, you can, at best, give half-unit increments. And many of the insulin pens only go in 1-unit increments. But for Aspart and Lispro, you can do 1.5 to 2.0 for children. But you can't do 1.75 units of insulin. And that might be called for in younger children who have a very high insulin to carb ratio. It's ideal for athletes to decrease their insulin delivery during events. You can set temporary basal rates that are quite low if they're going to be doing cross-country running. As I mentioned, it's ideal for infants because you can give tiny amounts of insulin accurately. And another thing that you can do with a pump that you cannot do with a pen is you can set what's called an extended delivery. Certain foods, and I would imagine, so we talk about pizza as the example, I would imagine hummus and other foods that are particularly rich in carbohydrate and fat have a prolonged absorption, and so you need a prolonged delivery of insulin. So you can tell the pump, oops, sorry, didn't mean to do that, that to give what's called a dual wave or an extended wave of insulin that protracts the delivery of the insulin over a longer period of time. The problems with pumps. And this is the top one, is the number one issue. When you give yourself an injection of glargine, Lantus, or I'm not sure if that's what it's called here, glargine or Detamir, Levemir, you have a background insulin that's going to last you at least 24 hours. There's a newer product called Tresiba, Degludec, that lasts actually longer. You're not going to go into ketoacidosis as long as you're taking a long-acting insulin. But on an insulin pump, you have no long-acting insulin. As soon as your pump stops delivering, if you have a kink in your catheter, an occlusion in the catheter, if it works itself out, you have no insulin. And you could easily be in ketoacidosis within 8 hours if you're not watching your blood glucose. So that you have to be vigilant. That's probably the number one downside of pumps. You need to be checking your blood sugar. You can't just be mindlessly entering carbohydrates into your pump and covering your meals and not knowing what your blood sugar is. Okay, and there are many body image issues for kids and especially adolescents. There are kids who just do not want to have stuff on them. They either are embarrassed about the diabetes, and in particular when you get into pumps and sensors, it becomes particularly troublesome for a lot of adolescents who just won't even wear them. Plus, they're very expensive. I'll mention subcutaneous glucose monitoring systems, continuous glucose monitoring systems. Just to point out, that's blood. That's where the sensor is. It's in subcutaneous tissue. You're not measuring blood glucose. It's glucose that's diffused to the to that electrode that's there. But so you're getting a constant reading, but it may be delayed at least 20 or 30 minutes from what's happening in the blood. Let me just show you so the advantages of these CGMs is that they'll not only tell you what your subcutaneous glucose is, they'll give you trends. They analyze the trend, and they'll tell you it's steady. It's typically arrows. Horizontal arrows, arrows slightly rising, quickly rising, slightly falling. It gives you trends, and it can predict low blood glucoses. Let me just go on and show you one other device called the Freestyle Libre. I think it's been in Europe longer than it's been in North America. We're just getting it now in the States. This is slightly different. It's a lower profile sensor that's here. It does not read continuous glucose. It's reading it, but it doesn't report it until you hold the probe right over it. So you interrogate the sensor with a device that's about that big, and it'll tell you the glucose. Now, it's keeping records of what's going on. You can download it, but you have to do that every 8 hours. But it's another way to monitor continuous glucose. So one other thing about these devices, you can also have them work through your cell phone so that a child who's at school can have their Dexcom G5 sensor sending a continuous profile, including the arrows, to the telephone of their parents, up to 5 people. The teacher can have one. We don't ask that the doctor's office monitor. We have 3,000 children with diabetes. We cannot follow everybody's blood sugar, but the parents can. So let me show you one last thing. In terms of data analysis, this is something that you don't have to be a tertiary care center to do. So this is a child I saw just last week. This boy has autism. He wears a CGM. So this is daily profiles of his blood glucose. You can see this day he stopped, it came out. So there's part of this, I think that's when he was in clinic. Here's a complete day of readings. You see some peaks here. There's a day where he was missing part of it. It's not very useful, right? I mean, it's useful in that you can look at the glucose level on the meter and say, gee, I'm 175, I'm about to have dinner, how much of a correction factor do I need to give? On the other hand, you can do this. You can have it overlay an entire week's worth of readings. But that's not all that helpful either. There's a color code up here. It's a little hard to see. I think it's kind of washed out here. But if you can see patterns in there easily, your eyes are better than mine for sure. But look at this view. So this is from the Dexcom Clarity App. Patients can download this, not just our office. But look at what we have here. The CGM is reading subcutaneous glucose every 5 minutes. It displays here the peak and the trough. We see the extent of them. That dotted line is the mean glucose. So you can kind of see trends here. You can see what's going on at different times of the day. If one day some of these are postprandial, some of them are preprandial, it doesn't matter. You can see what's happening. And if you look at this a little bit more closely, we can see here like the median glucose with no excursions into anywhere near low is a little bit high during the night. This kid needed a little bit of a basal rate increase overnight. You can see that there were a few times when there were drops. That's because the mother was checking on his blood sugar and giving corrections during the night. Not under our instructions. We usually don't have people do that, but hopefully, so we discussed that. But you can see we did that. We saw that he had postprandial drops after lunch. The insulin to carbohydrate ratio was too strong at lunch. We were able to reduce that. And one last slide. This is now what you can do with blood glucose from a glucose meter. This is insulin. These are glucose levels off a Dexcom pump. In the pump, it actually stores your blood glucose levels, and so every day of the week you can see a top line it doesn't show up well here at all, but you can see the top line is where the glucose level is, the carbohydrates that the patient entered into the pump. This is how much pump insulin was delivered. You start to look at those, and you can start see patterns. But look at this picture right here. This is all of these displayed is a scatter plot. This is midnight, that's midnight, for the last 30 days. A couple of things you can see from this. This patient's been checking on average 6.1 times a day. She gets a good pat on the back. Some teenagers come in with 1.2 times a day. And when I challenge them, they say, oh no, every time I eat, I check my blood sugar. And I say, 1.2 times a day? It's kind of like, no. But you can monitor how often they're checking. It'll tell you how many are in target, how many are above target, how many are below target. But you can see patterns here. Look, right there. She also was waking up high. It's hard to see, but it's shaded between 80 and 180. She needed a higher basal rate. Her readings at lunch were too high, so she needed a stronger insulin to carbohydrate ratio at breakfast. And we see these scattering of high readings in the afternoon. That's because when we finally got around to discussing it, she felt like, well, she was snacking often and not really covering it. I think I'm going to stop here, but I just wanted you to see these are tools that you don't need to be in a tertiary center to do. A doctor's office can have these tools. This gluco is available online. The Dexcom Clarity, patients can download this and analyze it. And we're getting to the point now where I don't really care about having patients do blood glucose readings anymore. I'd rather all of them be on a CGM. You still have to prick your finger with the Dexcom 5 twice a day to calibrate the meter, 12 hours apart. But after that, I don't care if they write down things in a book. I think we're heading for much better things. I think I will not go any further. I showed you this data last year. We're getting good experience with the closed loop insulin pump. It has been, as predicted, very good at preventing lows at night. Look in the purple area here. It's still not perfect at controlling blood sugar during the day, but they're getting better and better. And I will end here. Please don't hesitate to contact me.